Okay. All right. So my topic is on approach to a patient with bleeding disorder, and I'm Kenna Sheik. I'm a pediatric resident at UNM. So objectives for this is just a quick, brief overview of hemostasis, because usually this is something that's quickly forgot, or I know that I forget it a lot. Other thing is just what is our clinical evaluation for bleeding disorder, also initial laboratory evaluation, and then what our common bleeding disorders are. And importantly, why this is important in adolescents is because a lot of these kids are usually going to be found to have a bleeding disorder early on in life. However, there are some adolescents that are missed until they start joining contact sports. And then also some of our adolescents, our female adolescents, may start having menorrhagia as well, or a little bit later on. So hemostasis, so we have primary and secondary hemostasis. Our primary hemostasis involves our platelets, von Willebrand's factor, and our vessel wall. So our platelets and von Willebrand factor get activated, go to the site of injury, and create our platelet plug. And then sometimes our vessel walls will either constrict or capillary walls will collapse completely to stop bleeding. This is only a primary hemostasis is only a temporary fix, usually lasting about 12 to 24 hours, and that's when secondary hemostasis begins to start kicking in, and that involves our clotting factors that leads to our fibrin clot formation, and the goal of that is to stabilization of our platelet plug. So coagulation cascade, I wanted to choose an easier, simple picture just for this presentation rather than some of the more confusing ones. The specific things to focus on is that we have our intrinsic and our extrinsic pathway, as well as our common pathway as well. So for extrinsic, we have factor 7 there, and then for intrinsic, important ones that we hear a lot about are factor 8 and factor 9, which is our hemophilia A and B, as well as in our common pathway are concerns with our fibrinogen, our prothrombin, our factor, and protein CNS as well. So clinical evaluation and history, big important things when you're initially evaluating the patient is their bleeding history. What's normal versus abnormal bleeding history, and we'll go into what our abnormal bleeding history is in a second. Other important things as well as our family history. So any family members that might have required transfusion for minor surgeries or due to menses, as well as other family members with similar bleeding history or bruising history that this patient might be presenting with. Also medications, if the patient is taking any NSAIDs, if they're on aspirin, if they've ever been on warfarin or heparin. And normally warfarin and heparin are usually going to be a lot less common in our pediatric patients. However, there are some that are on it. So for abnormal bleeding and history, physical exam, so bruising, big things to pay attention to are petechia, which you can see in that bottom corner there. Small capillary hemorrhages that are present. They can be present inside the mouth, on the in the mucosa, as well as on the extremities, on the face. And then also bruising out of proportion to our mechanism of injury. So if the family comes in saying that, you know, they were just playing around and they fell and they noticed that they have a large bruise. Other big things to also pay attention to in your history is if you had concerns for any kind of abuse, those might be other warning signs that may lead you against concern for a bleeding history. This upper picture here above the petechiae is a hemarthrosis, and is very common in a lot of kids with bleeding disorders to get these, usually from minimal trauma, and then they get bleeding inside of that joint. So other things to pay attention with bruising is also just associated hematomas as well. That would be an abnormal sign. So other abnormal bleeding, epistasis. So lots of kids, especially here in New Mexico, will have bloody nose just because of how dry it is and the weather. However, if the bleeding nose is either bilateral in both nostrils, if it requires an ED visit, if it's not relieved by 15 minutes of adequate pressure, and this is why I put up the picture of the Kieselbach plexus, the pressure is usually applied in that area, and after 15 minutes they're still having bleeding, that's abnormal. Also, other associated bleeding signs, we talked about bruising earlier. If they're having menorrhagia, if the patient comes in and they have pallor, they're tachycardic, they're hypotensive, things like that. Other things are post-surgical. So if you have a patient who comes in who has bleeding beyond a surgical site, if they had a tube that was placed initially, had IVs, those are concerning signs. If the patient needed a transfusion after surgery, especially if the procedure note that you received doesn't seem to relate as much for needed reason to receive a transfusion. Also, some of our patients who get TNAs, if they have postoperative bleeding 7 days following that TNA, that's also another concerning sign. So menorrhagia, a lot of adolescent females who have menorrhagia, except what is menorrhagia? So menorrhagia, normally, if you're asking your female patient, if they're having to frequently change their pads about every 2 hours or so, if they're having menses for longer, sorry, that should be greater than 7 days. And then menses occurring more than once a month. And here, so the American Academy of, or College of Gynecological and Obstetrics, I'm butchering the name, excuse me, has actually recommended that many of the women who have menorrhagia, especially adolescent females, possibly get tested for von Willebrand's disease because it's very common. And so actually one of the things, if you want to get a better idea of what these women are going through when you're talking to them, is this diagram here that they put out in terms of how much they're soaking their pad, what days they're soaking their pad, if there's lots of clots, or if they're using tampons as well. And it's also important to make sure you're asking these patients as well about their moms, their sisters, their aunts, any other history of menorrhagia in them as well. So our laboratory examination, so for a screening examination, if your patient seems to be stable enough and doing well enough, the initial screening would be prothrombin time, which measures our extrinsic and common pathway, which I put up again on that side there. Our activated partial thromboplastin time that measures our intrinsic and our common pathway, and a platelet count. But normally most of us are going to get a CBC just to make sure that the patient's not severely anemic or having issues that need to be taken care of urgently. So for a differential, when we're doing our specific screening tests, so if we have an increased PT, some of the common things that we might see in our differential might be acquired factor 7 deficiency, and acquired being that they weren't born with it, so you may be concerned about early liver disease, if they have an early vitamin K deficiency, and if they're on warfarin. However, I said not a lot of our patients will be on warfarin. If we have an increased PTT, our common things are going to be deficiencies of factor 8, 9, 11, also, von Willebrand's disease can present like this. Another thing that may present with this as well is lupus inhibitors or antiphospholipid antibody syndrome. However, one important thing to note about that is that if you have a patient who comes in and you're concerned about antiphospholipid antibody syndrome, they're not going to be presenting with bleeding. You're going to be more concerned about clotting, but for some reason they also have an increase in PTT. So if you have a normal screen on your PT, PTT, and platelets are normal, a common thing might be mild von Willebrand's disease, as well as mild factor deficiency 8, 9, and 11. And because these kids didn't really have any concerns earlier on and may have actually presented with bleeding signs later on when they got involved with contact sports, or for females once they started menses. In terms of our low platelets, our common thing is increased platelet destruction and then decreased platelet production. Our more rare things, and these are things to think about also in our women who have menorrhagia, is there have been a few cases of Bernard-Solier syndrome, and then also if you're concerned about myeloproliferative disorder, which is important to get that CBC in the first place to look at the other cell lines. Other subsequent tests, by this time you're probably already getting hematology involved if you haven't gotten them involved sooner. They may recommend a PFA 100, and what that does is it actually able to look at the platelets and how many platelets there are and are these platelets functional. So if your PTT is abnormal, you might get a PTT mixing study, factor assays for 8, 9, 11, and 12. Lupus anticoagulants, we talked about the antiphospholipid antibody testing. Other things would be that if the PT is abnormal, you might get a PT mixing study, a factor 7, protein C, and S activity. And then other specific testing for von Willebrand's disease, if you're concerned about your adolescent patient with menorrhagia, or they have late presenting symptoms for bruising after they started soccer or football, you might get a risk-associating cofactor activity, as well as a factor 8 activity level, and then a von Willebrand's antigen level. So going into our more common inherited bleeding disorders, so hemophilia A is a factor 8 deficiency. It's X-linked inheritance, and it's 1 out of every 5,000 to 10,000 people. Hemophilia B is a factor 9 deficiency. It's also X-linked inherited, and it's 1 in every 30,000. Von Willebrand's disease is our most common inherited bleeding disorder, and that's 1 out of every 100 births. And this is why a lot of the gynecological groups suggest that women with menorrhagia get tested for von Willebrand's disease because of how common it is. Other important things to note is that even though if we may have a history of if we may not have a family history of a bleeding disorder earlier back on, a lot of our hemophilia A and B, about 1/3 of patients will not have a family history of bleeding disorder in their family. So for hemophilia, our clinical classification, so mild hemophilia, you have 6 to 40% factor activity for 8 and 9. Incidence for factor 8 is 70% in mild hemophilia and 50% for hemophilia B. So normally, to cause bleedings, they have to have a major trauma or a major surgery. So this is why some of these patients, they may not present until their adolescence when something comes up like this. And usually frequency of bleeding is very uncommon. Moderate hemophilia, you have 1 to 5% factor activity. Our incidence is 15% for hemophilia 8, and then 30% in hemophilia B. Oh, sorry, I said hemophilia 8. Hemophilia A, excuse me. So these are more minor trauma as well as early and spontaneous usually. The frequency of bleeding is 4 to 6 times a year. So our moderate hemophilia as well as our severe hemophilia are probably going to present earlier on in our neonatal period or early childhood. So for our severe hemophilia, you have less than 1% factor activity. Our incidence is 15% for hemophilia A and 20% for hemophilia B. They have spontaneous bleeds, and the frequency of bleeding is 2 to 4 times a month. So for our von Willebrand's disease, we have type 1. That's 60 to 80% of all von Willebrand's cases. It's autosomal dominant compared to our hemophilia A and B. You have mild to moderate bleeding, and then when we're looking at those testing, we have decreased von Willebrand's factor antigen and decreased risdiplam cofactor activity. They usually have low normal to mildly decreased factor 8 levels. And in our type 2, we have 20 to 30%, and this is also autosomal dominant. They have normal levels of von Willebrand factor. Multimers that you will usually test for are structurally abnormal, and they have mild to moderate bleeding. Our type 3 is an autosomal recessive, and this is the most severe form of von Willebrand's disease, most likely to present a little bit earlier on than later adolescence. And this one resembles hemophilia A. So you have no detectable von Willebrand's antigen and very low factor 8, and then you have decreased risdiplam cofactor activities. So these are my references, and then any questions?